A very good morning to all of you. We welcome you again, once again this Sunday with another webinar in our CPD webinar series, co-organized by the GMOA and the Sri Knowledge Academy in collaboration with the Sri Lanka College of Internal Medicine. As usual, let me get into the housekeeping rules. This webinar link will be available from 9 a.m. to 9:50 a.m. for all of you to join in, and no late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to the NCCPD guidelines. We will be posting the pre-assessment and the link for the certificate at the end of our webinar. We will also be having a question and answer session as usual, so please feel free to type in any queries you have during this webinar so that we can discuss at the end. And we have imposed these rules to maintain and improve the standards of our CPD programs conducted here by Sri. And we thank you all for strictly adhering to these CPD guidelines. Without further ado, I would also request for all of you to switch off your camera and to mute your microphone so that there will be no disturbances during this webinar. And we will also post a phone number in our chat box in case you all get logged out. Please send us a message so that we can let you in back to this program. Today, we have a very interesting topic, a very timely topic, evaluation of anemia from a physician's perspective. So without further ado, I would like to give the floor to Dr. Himal, who's with us once again, to give a very appropriate introduction to our very distinguished speaker for this day.
Thank you, Dr. Romali. Right. It's my great pleasure to introduce today's speaker, resource person of us, Dr. P. Mayurathan, MBBS, MRCP, MD, FRCP. He's currently working as, Dr. Mayurathan currently working as resident physician in TH Badiklo since 2015. He has joined as a senior lecturer in medicine, Faculty of Health Sciences in Eastern University, Sri Lanka since 2017. He is an honorary consultant physician in University Medical Unit Teaching Hospital, Badiklo. He is a consultant physician in charge COVID-19 treatment unit in Teaching Hospital, Badiklo, and he is an academic coordinator in Psychiatric Department, Clinical Science of Faculty of Health Science in Eastern University. And same as his clinical coordinator, Faculty of Health Science, Healthcare Sciences, Eastern Province, Eastern University, and he's a member of board of study of radiology in post PGIM, and he's a member of board of study BSc Honors External, Eastern University of Sri Lanka. He has a lot of clinical interests, including endocrinology, diabetes, obesity, and NCDs. And he's an international clinical fellow of diabetes and endocrinology, and he has gained his training in Royal Hampshire Country Hospital in Hampshire in United Kingdom. So he is here with us to deliver one of very important topic to evaluate as a clinicians as well as any clinician in any field. So without further ado, I would like to invite Dr. Mayurathan to give his talk. Thank you.
Good morning,
Dr. Mayurathan, session is over to you, sir.
Yeah, thank you very much, Himal, and the organizers for inviting me. Today, we are just going to discuss about evaluation of anemia because you all know that nowadays anemia is a common problem in Sri Lanka as well as in many other countries. So it's not a lecture, it's just kind of a discussion. You can ask any questions. In a patient, whenever you see a patient with anemia, the history and examination are very, very important, as you all know. So first of all, you will be evaluating the symptoms as well as the signs of anemia. When you evaluate, in addition to the symptoms and signs, better to go through any evidence of hemolysis. Say, for example, in addition to the anemia, if you see patient is icterus and there may be a splenomegaly, then that could be due to the hemolytic anemia. At the same time, after evaluating the symptoms and signs, better to evaluate for the complications. Say, for example, if the chronic anemia persists, if the patient may develop heart failure, then we may have to go through the cause of the anemia. Say, it could be nutritional or sometimes the chronic blood loss, maybe familial or hereditary causes, something like that. You may have to think about what could be the cause for the anemia in your patient. So the other important point to remember, the red cells are produced by the bone marrow. So there may be only isolated problem like anemia, or there may be other cell line involvements, like there may be thrombocytopenia, there may be low white cell count. So you may have to evaluate for that. Say, for example, recurrent infections or bleeding issues may be suggestive of other cell line involvement. Then, better to ask few stories about the family history. For example, is there any other family members having similar kind of problem? Maybe getting regular blood transfusion, or maybe undergone splenectomy, like some those informations may be very important for a patient with anemia. So you all know the symptoms and signs of anemia. So it's a long list. We all have studied from the undergraduate level. So better to go through that. Especially when this anemia is there from the childhood, the school performance, the concentration, everything may go down. So that also we have to keep in mind, whoever is doing the pediatric work. And also this anemia is very common in elderly people as well. Remember, that is also a huge problem in Sri Lanka. So it affects all variety of people. So as a basic thing, when we classify the anemia, the blood picture is very important. More than that, the red cell index, especially the MCV, mean corpuscular volume. So we classify the anemia based on the MCV or blood picture, or even red cell indices like MCV is enough. So microcytic anemia and normocytic anemia and the macrocytic anemia. So this is we are studying from the undergraduate level. The microcytic anemia are commonly due to iron deficiency, thalassemia, or scleroblastic anemia. Sometimes it can be due to anemia of chronic disease or chronic lead poisoning. Those are the common causes. Then again, macrocytic anemia, the MCV is high. It can be divided into macrocytic megaloblastic or macrocytic normoblastic. So basically, two are the more important causes for macrocytic and megaloblastic anemia, that is B12 and the folate deficiency. Other causes like liver disease or chronic alcoholism, drugs, pregnancy, hypothyroidism, cirrhosis, those can be macrocytic but without any megaloblastic anemia. Then the normocytic anemia again can be divided into based on the reticulocyte count, and I think that it's very simple classification. So now let's move on to the first question. A 28-year-old woman presents with excessive tiredness for 3 weeks duration. On examination, she is pale, and all her limited system examinations are normal. Limited system means usually you do on the ward. We don't do very detailed system examination. So we do generally the limited system examination. Means whatever you do normally, routinely do on your patients admitted to the ward is the limited system examination. Sometimes after the limited, we are going into the details sometimes. We don't know. You know that every patient, we don't do all the detailed system examination. I hope you can hear my voice. Sorry for the interruption. Yeah, the patient investigations, the patient has hemoglobin of 6.4, which is low. WBC also, WBC is normal, but platelets are raised. MCB low, red cell distribution width is high. CRP and creatinine are normal. So what is the most likely diagnosis? So you will see this kind of blood counts almost every day in your wards. So how do we evaluate that? Usually we go simply, these are the major parts in the full blood count. So the MCV is low, so it's microcytic. Then we always check the red cell distribution width. So in thalassemia patients, red cell distribution is normal, but in iron deficiency anemia, because of the different shapes and the sizes of cells in the blood picture, so you will get the red cell distribution with the higher level. So the most likely diagnosis in this patient is going to be iron deficiency anemia. So it's very simple. You have to be, if you see anemia, just check the MCB and the red cell distribution with MCB is low and the RDW high is highly suggestive of iron deficiency anemia. So the iron deficiency anemia, so how do we investigate? So first investigation is always blood picture. So that will be like microcytic hypochromic red cells with various kind shapes and the size. We say anisopoikilocytosis. I will show you the blood picture. Then our investigation is going to be serum ferritin most of the time. But if you have facilities, you can go for transferrin saturation or serum iron and iron binding capacity. But remember, if you are going to do the ferritin level, it is again acute phase protein. It will be elevated in the inflammatory condition. So we always advise you all to do the inflammatory markers like ESR or CRP. If those are normal, then the inflammation is not there, then you can perform ferritin level. If those inflammatory markers are high, if you do the ferritin level, it may be falsely high and saying you wrong interpretation that this patient has adequate level of ferritin. Therefore, always better do the inflammatory markers before arranging the serum ferritin, because serum ferritin is a little expensive investigation. Then you know the common causes for iron deficiency. Maybe nutritional, chronic blood loss, maybe due to peptic ulcer disease or hemorrhoids. Some other common cause among young females is the anorexia. And still we are having significant number of patients with worm infestation. And sometimes the pica also common in parts of Sri Lanka, some parts of the Sri Lanka, because of the traditional issues and all. So you have to go through the causes. If you see the blood picture of iron deficiency anemia, you can see these are the hypochromic microcytic cells. In addition, there may be few teardrop cells, not many teardrop cells. There may be pencil-shaped cells. There may be one or two target cells, not many. So those are highly suggestive of iron deficiency anemia. You can see the small dots are platelets and the white cells all are adequate in this blood picture. So this is telling us that the white cell and the platelets may be adequate in the number. So whenever you see the blood picture, so always after seeing the red cells in anemia picture, just look at the white cells and the platelets also, because the patient may be having other problems also. So just quickly run that. So then how are we going to manage iron deficiency anemia? It's very simple. So first of all, we have to assess the nutritional status of the patient. If you think nutritional is the cause, because if it is a nutritional malnutrition causing anemia, there may be other micronutrition deficiency as well. So we may have to treat that also. And very important, we have to identify the cause and treat the underlying cause. For example, if you think the patient has menorrhagia, and refer to the relevant team. If you think upper GI bleeding is there, and get the upper GI endoscopy done. So sometimes you will come across some patients. There is no obvious cause for the iron deficiency anemia in your patients when you do the history and examination. So you couldn't find a cause. So in those situations, definitely we have to think about GI causes. Simply, it could be a GI blood loss, or it could be something like dangerous conditions, GI malignancies. Okay, you should remember the periambulary carcinomas and also the colorectal cancers are the common other presentation is the iron deficiency anemia. Okay, so in those situations, definitely you may have to do upper GI endoscopy. That is normal. Definitely, we have to perform lower GI endoscopy as well. So remember, especially in middle-aged or elderly patients, if you couldn't find a cause for the anemia, we have to arrange upper GI followed by the lower GI endoscopy if upper GI is normal. Okay, and also we have to advise about the proper diet with iron and as well as the other components. So better to advise about the balanced diet. So in this patient, so patient is symptomatic as well as the anemia is below 7. So we say below 7 is severe anemia, 7 to 10 is the moderate anemia, and more than 10 is the mild anemia. So this patient has severe and symptomatic anemia. You have to transfuse blood. And you know 1 unit of blood transfusion will increase the hemoglobin by 1 gram. So in this patient, at least we may have to give 1 unit to get the hemoglobin more than 7. And start iron supplements. We have oral iron, IV iron, IM iron. So depending on the facilities available in your hospital, you can choose whatever the appropriate therapy. Remember, oral iron is easy and cheap, and sometimes it may cause some side effect like digestion, sometimes different taste or something, so patients may not tolerate. If you think they can't tolerate, then you can go for other ways of giving iron like IV iron or IM iron. So these are available in most of the hospitals in Sri Lanka. There are formulas to calculate how much you have to give. You can go through that and give the dose. So IV iron is relatively safe, and it is the best way to get the irons to quickly. But the efficacy wise, all are same. So whatever the way you give the iron, so it's going to increase the hemoglobin by 1 gram per week. So whether you give IV or IMO or oral iron. But anaphylaxis may be a problem in IV iron. So whenever you start IV iron, you may have to closely monitor the patient for any reaction. And IM iron may be causing reaction. Okay, so you have to keep in mind. And the other common problem of IM iron is the staining. So whenever you put it into the deltoid, that area, the IM area, maybe around the injection, there may be black color staining on the skin that might be there for a longer period of time. So if you are giving it for a young females, there may be some cosmetic problems because the patients, there may be big scarlet, blackish discoloration on the skin for a longer period of time. So you have to think about it. And remember, so we have to keep on monitoring this patient at our clinic, because it can't discharge because we don't know what is going to happen. Sometimes the poor compliance, patient's hemoglobin may not pick up, or sometimes patients stop the iron treatment in the middle and they just go on with the mild anemia for a longer period of time. Then later on they might come with a heart failure. Okay, so if you are giving patients compliance is correct, so but you couldn't achieve your expected hemoglobin raise, then you may have to think about other possibilities for ongoing blood loss, something. So you have to keep them monitor for a significant period of time. So generally, so how long we continue this iron treatment is another question among the young doctors. So usually what we do, we give the iron supplements until you get the hemoglobin around 12. Then after that also better to continue for at least 2-3 months to get enough iron stores in the blood. So don't stop that. It might take at least 6 months minimum period to get the adequate iron stores and the hemoglobin for iron deficiency anemia patients. So that's about iron deficiency anemia. Then we will just quickly run through the hemolytic anemias. So hemolytic anemias you can divide basically into 2 types. Some are called inherited and others are acquired. So inherited conditions are maybe due to membrane defects, enzyme defects, or sometimes we say hemoglobinopathies. All are kind of hemoglobinopathies anyway. So membrane defects are only 2 causes: hereditary spherocytosis and hereditary erythrocytosis. And the enzyme defects again 2, G6PD deficiency and pyruvate kinase deficiency. Again, the hemoglobinopathies may be due to sickle cell anemia and the thalassemia. Anyway, under each category there are 2 major disorders, so easy to remember. And the acquired causes can be divided into immune and non-immune mediated hemolysis. So non-immune mediated hemolysis is relatively rare. We don't see many patients, but there may be some serious conditions like hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, more than that DIC, something like that. You may be seeing patients with non-immune mediated hemolytic anemia, even though it is rare. But if when you get a patient, these patients are most of the time very ill patients, and we may have to give significant care to them, otherwise we might lose them. Okay. And immune-mediated hemolytic anemias again can be divided into alloimmune-mediated hemolysis and autoimmune-mediated hemolysis. So autoimmune-mediated hemolysis again could be divided into 3: warm, cold, and paroxysmal cold hemoglobinuria. And you may come across patients like this. These are not very, very rare conditions. So at least in the medical wards, we come across this kind of patients, maybe 1 or 2 patients every month. So this is the basic classification of hemolytic anemia. Then again, the hemolytic anemia could be intravascular and extravascular hemolysis, and these are the examples. Now we will move on to the question number 2. A 10-year-old boy presents with tiredness. Investigations showing that hemoglobin 7.1 with the normal WBC and the platelets, but you can see MCV is very low and RDW is normal. So this is the difference between iron deficiency anemia and the thalassemia. So in iron deficiency anemia, we say MCV will be reduced proportional to the hemoglobin with the higher RDW. But in thalassemia patients, the MCV reduction is very significant. Very significantly, MCV is reduced, very low MCV compared to the hemoglobin, and the normal RDW is the typical full blood count appearance of thalassemia patients. So the diagnosis here is going to be thalassemia. Because of this degree of hemoglobin at the age of 10 years, we have to think about thalassemia major. So it can't be the thalassemia carrier or intermediate. Those patients usually having very mild hemoglobin, and they are usually asymptomatic thalassemia carrier patients or minor asymptomatic. That is usually an incidental finding when we investigate for some other problem. But here, this patient is 10 years and symptomatic, and the hemoglobin is significantly reduced, almost at the level of severe, close to 7. So that's the reason. So we usually it could be most of the time due to the thalassemia major. So the best investigation to confirm the diagnosis, that is the question. So we can do the blood picture, but that is not a confirmatory investigation for thalassemia. And serum ferritin we always do for because it will be normal or higher ranges when we start to treat the patient. Bone marrow examination is not the first line investigation or confirmatory investigation for thalassemia patients. Ultrasound scan abdomen also we do because these patients are having hemolysis. So they will have a splenomegaly, and the cause thing we have to look for to decide about the treatment. So the confirmatory investigation is going to be HPLC, so high performance liquid chromatography, or sometimes we say hemoglobin electrophoresis. Those things can be done. So in addition, if this is a kind of hemolytic anemia because patient is having anemia, jaundice, as well as the splenomegaly. So this is hemolysis as a basic investigation to confirm whether is there any hemolysis. You can do the reticulocyte count. It will be high, usually more than 2%, and the LDH level also will be high. Those things are telling us that this patient is having a hemolysis. To confirm that, we can do the indirect bilirubin fraction, so that will be high. And other investigation you can do based on wherever you work, what are the investigations available in your hospitals. Okay, so sometimes we do HbA2 level, and all that also will be high in thalassemia patients, but those are not actually very relevant to make the diagnosis, because whenever you suspect thalassemia, just send for blood picture, and followed by the hematologist will suggest to send HPLC, then we can confirm the diagnosis. It's not a big deal. So you have to think that anemia in thalassemia due to three major possibilities. One is they are having ineffective erythropoiesis and hemolysis. More than everything, they develop high splenomegaly and hypersplenism. So that is again consuming red cells and causing anemia. So that is the reason we always do splenectomy in these thalassemia major patients. Okay, so we do that. So, very sorry, even the question is about male, so this is the image of a female, because of the extramedullary hemoptysis, they can have dysmorphic features on the face. You can see busting of the forehead and also prominent maxilla and so many other features. And if you do the X-ray, you can see hair on end appearance. There are some of the features of thalassemia major patients. So if you do the blood picture of thalassemia, in addition to the hypochromic microcytic cells, you will see lot of target cells. These are target cells. Huge number of target cells, and also there may be other shapes like teardrop, 1 or 2 teardrop cells, and other evidence of hemolysis may be there, but the major important findings in the blood picture of a thalassemia patient is hypochromic microcytic cells with more number of target cells, and you can see the platelets are adequate in number, and also white cells are, you can see the white cells also. It says those may be normal and in the number, but anyway we need hematologist opinion to report this. So how are we going to manage these patients? Very important, because thalassemia major is usually diagnosed at very younger age, maybe few months of life or years of life. Usually the pediatricians are diagnosing this disease. So, or sometimes only adult cases we diagnose. So we have to explain to the patient as well as the parents, not only about the disease, we have to talk something about the diet and the treatment complications, because thalassemia major patients are not going to be normal people when they aging. Okay, it's because of the frequent blood transfusion and the iron overload and the complications, they will be having problem. So in addition to treating the patient, we may have to do a family screening, very important. at least do the full blood count and the blood picture of the family members first. Then whoever is having features of thalassemia can undergo HPLC, because HPLC may not be available in all of your hospitals. And these patients should have regular blood transfusions to keep the hemoglobin more than 10. Remember, more than 10. Okay, so even 11 is all right for them to have a normal life or near normal life. If the hemoglobin is low, below 10, they can't be normal people. So we have to keep in mind and give a regular blood transfusions. We know that roughly about when we start give 50 blood transfusions, they start to develop iron overload. So they need a kind of iron chelating agents. So there are various kinds and various methods, or various routes can be given: oral, cutaneous route, intravenous route. There are various preparations available. So depending on the facilities in your hospital, you can choose. And we have to refer to the hematologist, because we need their input also, especially for thalassemia major cases. And splenectomy is indicated. As you know, when we go for splenectomy, then we have to give vaccines, and they have to be on regular vaccines. In addition, oral penicillin to prevent some certain kind of infections. Okay. So those things are very important in a patient manage patients. Now I'm moving on to the third question. A 45-year-old man with a chronic kidney disease is under evaluation for anemia. The patient's hemoglobin is around 8. Question is most appropriate investigation before starting erythropoietin. You know that CKD patients, we are giving weekly erythropoietin. So what could be the appropriate investigation before starting erythropoietin? So serum ferritin is the answer. So we will discuss about that. Even though erythropoietin deficiency is the common cause for anemia in CKD, we should think about other causes. Remember, there are many other causes for anemia in CKD. Simply, you know, CKD patients are having very severe loss of appetite, so that their intake may be poor. Even though they eat, because there will be edema, including the gastrointestinal tract, there will be absorption problem in these patients. So that also could contribute to the anemia. And because of the stress as well as the edema in the GI tract, there may be mild chronic GI blood loss that also may be contributing. And remember, severe uremia can cause reduced red cell survival. Okay, so premature destruction of the red cells, that also can contribute to the anemia. Hemolysis through the dialysis machine is very, very rare condition. And also this uremia can cause bone marrow suppression. And also when they go into secondary tertiary hyperparathyroidism, there is a possibility of bone marrow fibrosis also in CKD, especially the advanced end-stage CKD patients. And remember, there may be interference with the erythropoietin release when we give AC inhibitors to CKD patient. That also a rare possibility of anemia in CKD. And whenever we give regular erythropoietin, there's a very rare chance of patient developing pure red cell aplasia. That also may be a rare possibility of anemia in CKD patient. That should be considered at last, after excluding all other possibilities. So keeping in mind, we have to balance the management of our patients. So first of all, we do the full blood count in the blood picture and look for what type of anemia your patient has. So you should remember, erythropoietin deficiency causes normocytic normochromic anemia. Okay, it's a normocytic anemia. So in addition, patients may be having poor nutrition or poor intake or GI blood loss could cause iron deficiency anemia that might reflect in the blood picture like microcytic hypochromic anemia. So blood picture is the first investigation, followed by we do the ferritin level. And we specifically looking for the ferritin level before we starting the erythropoietin, because erythropoietin is a hormone which will be effective if the patient has adequate iron stores in the blood, in the body. So therefore, we should make sure the ferritin level is adequate before we give the erythropoietin. Roughly, remember, we have two numbers, 100 and the 200. The CKD patients who are not on dialysis should have the ferritin level at least 100 to start the erythropoietin. Other way, if the patient is on regular dialysis, the ferritin level should be around 200 before we start erythropoietin. Okay, so if the patient is having ferritin level below the targets, then first of all we have to give iron to get the enough ferritin storage in the body. Then only the erythropoietin is going to be effective. So in these patients, the oral iron may not be very effective because of the poor absorption due to GI edema. So better to go for intravenous iron because that will quickly replace the storage of iron in the body compared to oral one. But the efficacy, I told you, same. So go for the IV iron, then check the ferritin again. Whenever you achieve 100 for a non-dialysis patients or 200 for a dialysis patients with chronic kidney disease, then you can continue the erythropoietin. At the same time, erythropoietin also, whenever you give, it should increase the hemoglobin by 1 gram per week. That is our target. So because you remember the previous slide, there are many possibilities for anemia. So you are giving correct dose of erythropoietin, the compliance is good, but you couldn't get the expected hemoglobin raise, then of course you have to think about other causes. Remember, bleeding or chronic blood loss and the nutrition should be considered very seriously in a CKD patient. And if necessary, you go for endoscopy, especially the upper GI endoscopy, followed by the lower GI endoscopy. Maybe dual pathology in these patients. That may be the reason for patient not to get the expected hemoglobin raise. So those investigations should be arranged. And also these patients may have anemia of chronic disease. So their underlying other comorbidities should be managed very well. That is also may contribute to the anemia. So patients should be on regular dialysis. If they are diabetic or hypertension, that should be very well controlled. So all the comorbidities should be very well controlled. Then only we can get adequate hemoglobin. So these patients also, our target hemoglobin in the CKD patients around 11. So okay, for that we have to work and adjust the doses of iron or erythropoietin and looking for other causes of anemia. Everything should be important. Then only we can achieve our target hemoglobin. You all know that, otherwise it's going to be very, very difficult. Very rarely you have done everything, no problem at all, but you couldn't get the expected hemoglobin raise. In those kind of scenarios, you may have to think about doing a bone marrow studies to look for any other bone marrow causes for iron deficiency. So anemia in your patients, say for example, it could be bone marrow fibrosis, or it could be pure cell aplasia. Those are the very rare possibilities should be considered at last before that we have to correct all other possible causes for anemia in our patients. Moving on to the fourth question. A 50-year-old woman presents to the clinic with peripheral neuropathy and also found to have pancytopenia. The examination shows anemia as well as the vitiligo. What is the most appropriate next investigation to evaluate her further? So the history itself saying patient is having anemia and also vitiligo. In addition, the patient has pancytopenia. So pancytopenia and the vitiligo, it's immediately telling you that it could be an autoimmune mediated cause. And pancytopenia and vitiligo due to autoimmune causes, you can think about immediately the B12 deficiency, is pernicious anemia. And also that is suggestive of peripheral neuropathy. You know, the B12 deficiency or pernicious anemia can affect all over the body, and it can present with various clinical manifestations. So most of the time, the history and the examination are pointing towards pernicious anemia. So the question, what is the next appropriate investigation? So blood picture, ultrasound scan, TSH, bone marrow, serum ferritin. So suppose the appropriate investigation is going to be the blood picture. If you see the blood picture of the pernicious or B12 deficiency anemia, this is again the common blood picture for the exams and all. You will see oval macrocytes. Okay, it's typical description. You have to say oval macrocytes because round, there is another macrocytes called round macrocytes that is very specific for other ways of hemolysis. Say for example, other causes of hemolysis, hereditary spherocytosis or hemolysis or everything, it's going to be round macrocytes. So you will see the oval macrocytes are very specific for B12 deficiency anemia. And other specific feature is the hypersegmented neutrophil. Okay, and there may be teardrop cells, one or two, but don't worry too much about that. So these two are the very specific features for B12 deficiency anemia. One is the oval macrocytes and the hypersegmented neutrophil. And that most of the time in the exam paper, especially if you are doing postgraduate exam, they might be asking you to list at least 3 or 4 clinical features of this blood picture. And you have to, I was telling you already, you have to look for all 3 cell lines in the blood picture. Here you couldn't see even a single platelet. There is no platelet at all. So that also you may have to highlight in the specific or characteristic feature of the B12 deficiency in blood picture. There will be thrombocytopenia because it is very common feature of B12 deficiency. Okay, so here you couldn't see any blood picture. So that should also be highlighted as a third characteristic feature of the blood picture, because that is again very important feature of B12 deficiency. Remember, in B12 deficiency, whenever you see hypersegmented neutrophils and the oval macrocytes, think about the platelet. Usually the exam slides are going to be no platelets at all. So you have to mention that as a third feature. So in this particular case scenario, this is a pernicious anemia, that is B12 deficiency due to autoimmune cause. So blood picture itself is enough for us to guess the diagnosis, because serum B12 level is not freely available in most of the hospitals in Sri Lanka. That is one reason we don't do. And other reason is it's a very expensive investigation. Okay, it's a very expensive investigation. So without doing B12, we always think about whether any other way of we can confirm the diagnosis. So these patients may be having atrophic gastritis, so you can do the upper GI endoscopy and the biopsy. There are 2 advantages for doing upper GI endoscopy and biopsy. One is if you take a biopsy and if it is proved atrophic gastritis, then that is again another way of confirming your diagnosis. Then other advantages, there may be in some time associated second pathology of upper GI bleeding that also could be excluded when we do that. And the antibodies, there are more parietal cell antibodies, intrinsic factor. So there are many other investigations can be done in the private sector, but these are very expensive in terms of government hospital and may not be available. So we don't do that routinely. So with the blood picture and the clinical features, we think about possible B12 deficiency. We think about starting the management and we indirectly see whether they are improving with the B12. So what you should do, in addition to this blood picture, you have to do the count also, reticulocyte count also. So then we start the treatment. Generally, all over the Sri Lanka, we have B12 injections. You can give IM injections, about 1,000 every other day for 6 doses. Then we go for every 3 months for lifelong, because in this case, it is autoimmune disease and it will be persisting throughout the life. So they might need regular B12 injection every 3 months after first 6 doses. Nowadays, oral B12 also available, but it's not available in the government sector, maybe available in the private sector, because whoever is having phobias with the needle can go for oral B12, can be given. But the easy way is giving IM injections. So how do we indirectly prove that a patient is having B12 deficiency? Is that another task for us? Repeat the retic count in about 1 week later. Usually the retic count is the one increasing in amount when we start B12 injection. That can be seen even after 5-6 days of starting the B12. And the hemoglobin is usually 1 gram increment will be there in 1 week time if it is a B12 deficiency when we start treatment. So these are the two things we see, and the clinical well-being, the symptoms of anemia will start to disappear very early, and retic count will be increased and the hemoglobin will be increasing with that. But the other features, especially the neurological complications or symptoms of B12 deficiency, will not be disappearing immediately. It will be persisting, and it takes many months, maybe 4-6 months to get the improvement in the neurological symptoms. So remember that we should explain this to the patient, otherwise they may be keep on coming to us with the neurological symptoms. So it can affect many systems. You can see hematological involvement, the neurological involvement can be the central nervous system involvement, and the spinal cord involvement, peripheral nervous system involvement, like many issues. Remember one more thing, depression and psychosis are other way of presentation of B12 deficiency. Okay, so whoever is coming with mental health related problems, also better to do the full blood count and the blood picture. Okay, so and in the full blood count, things MCV is going to be high, and usually this is MCV will be more than 110 in B12 deficiency. Remember, always you should think about B12 deficiency if the MCV is more than 110. So those are easy numbers to remember. So it can cause peripheral neuropathy, okay, and cardiovascular complications, gastrointestinal complications, like many problems can be there due to B12 deficiency. So moving on to the final segment of the presentation. So there may be pancytopenias. So pancytopenias can be easily divided into peripheral causes and the central causes. It can be very easy in the clinical practice, because whenever you see the pancytopenia, your next investigation is going to be reticulocyte count. Okay, if the reticulocyte count is high, we know that there will be peripheral destruction, and the bone marrow is reflectively producing higher amount of retic count. So it is due to peripheral causes. But pancytopenia, when you do the retic count is very low, then we know it is due to central causes. Okay, peripheral causes may be due to hypersplenism or autoimmune mediated or antibody mediated breakdown of cells. Okay, central causes may be due to bone marrow, maybe aplastic anemia or bone marrow related malignancies, sometimes bone marrow infiltrations. Okay, simply or bone marrow suppression. Simply the uremia can cause bone marrow suppression. TB, okay, disseminated TB can cause bone marrow suppression, and myelofibrosis or bone marrow related malignant conditions, and megaloblastic like B12 deficiency and hemophagocytic syndrome. So those are very rare possibilities of pancytopenia. Anyway, your investigation is going to be full blood picture and retic count. Then we do other investigation depending on our suspicion. Okay, so history and examination as usual, very important to evaluate all three cell line involvement. And with the history and examination, we might come to a certain differential diagnosis. What could be the possibility? Then your other investigations are going to be blood picture, retic count. Then other set of investigation. It is not in this order, whatever the order you can do. Depending on your suspicion, maybe you can go for LDH, ANAs, ultrasound scan abdomen to look for organomegalies, chest x-rays to look for any evidence of TB, and the hepatitis B, C, retroviral screening. And definitely we might need hematologist opinion for further evaluation and the management. So one of the causes for aplastic anemia, one of the causes for pancytopenia is aplastic anemia. So aplastic anemia is another condition we should remember. There are many causes you can see in the list, and related most of the time, the aplastic anemia patients will have no any organ involvement. Okay, no hepatomegaly, no splenomegaly, but patient will be having all three cell line involvement is the characteristic feature of aplastic anemia. If you see any organomegaly in a pancytopenia patient, remember aplastic anemia is going to be very, very, very less likely possibility. So that, of course, the clinical point you may have to remember. The final question, a 63-year-old man is presented with fever and diagnosed to have atypical pneumonia due to mycoplasma. The house officers commenced on IV cefuroxime, but patient was, say for example, stable for the first 2 days, but the 2 days later, suddenly the patient started to develop anemia, which is very significant, dropping from 12 to 8, and noticed jaundice. So what is the next step in the management? So we know that we have seen the causes for hemolysis. There are hereditary causes and acquired causes. So under the acquired causes, we may have talked something about autoimmune mediated hemolytic anemia. So there are cold as well as the warm type of autoimmune mediated hemolytic anemias, and the warm type is usually due to IgG antibodies, and the cold type is usually due to IgM antibody. Usually the warm type of autoimmune hemolytic anemias are this autoimmune conditions, say maybe like SLE, or drugs like methyl dopa, cephalosporins. They can be the common causes for warm type autoimmune hemolytic anemia, and lymphoma can cause warm as well as the cold. The cold type of autoimmune hemolytic anemias are common in infections like mycoplasma and viral infections like cytomegalovirus or Epstein-Barr virus. So the viral infections are common cause for cold type of autoimmune hemolytic anemia. And lymphomas again can cause cold as well as the warm type of hemolytic anemia. So here, well-known feature is the mycoplasma. It causes atypical pneumonia and it affects in our body almost everywhere. So it's a multi-system involving disease, including the hemolysis. So what is the immediate next step in the management? So that is the question. So here, the few answers are correct. Say, for example, sending the DAT, okay, direct agglutination test or direct comb test, that is also correct. and starting appropriate antibiotic to cover the atypical organism, that is the clarithromycin, that is also correct. And sending blood picture, yes, to see any evidence of hemolysis, very basic investigation, that's correct. And sending LDH to see any, so all are correct. Four answers are correct, no need to shift to the meropenem. So that is the inappropriate answer. The question is, what is the immediate next step in the management? So first step is going to be starting him on oral clarithromycin and sending all other investigations, especially the Holmes test, blood picture, LDS can be sent immediately after starting clarithromycin, because we have to stop the hemolysis. So first of all, you start the clarithromycin and send the investigation, because that is going to be the very important next step in the management. And slide of hemolysis, you can see agglutinations, but because we know that I was talking about warm type as well as the cold type, so this is depending on the body temperature. So simply the warm type of hemolysis is happening in our body temperature. The whole type of hemolysis is usually in a very low temperature, like around 4 degrees Celsius, something like that. So when they take the blood sample outside, when they examine it, the temperature is changing. It is the outside temperature is not very cold, not very warm. So they may not be able to see this typical blood picture appearance sometimes. So the history and examination is very important. Then only the lab people may be thinking about this hemolysis, and we may have to send this Holmes test is positive and LDH reticon those are high, then they may be doing special adjustments to see any evidence of hemolysis. Sometimes you may have come across this problem. A blood picture, sometimes they might miss the hemolysis because the temperature changes may alter sometimes the blood picture findings. But it is not a big deal for the hematologists. They will do, and easy to say there is evidence of hemolysis. I think that's all, because anemia is a very big topic. I have taken about 5 questions to address common problems in the clinical practice about anemia. Now this is your time to ask questions.
Thank you, sir, for that very informative lecture. So we have collected so many questions, sir. It's about 15 questions we have here with us. So we'll start one by one.
Yeah.
The first one, how to differentiate thalassemia from iron deficiency with the red cell indices?
Yeah, I have already given the answer.
Yes.
So simple, very simple. With the anemia, just check MCV and the RDW. So MCV is proportionally low, with the high RDW is iron deficiency, and MCV is disproportionately very low MCV, and the normal RDW is suggestive of thalassemia. So that's the information with the full blood count. Then you have to do the blood picture.
Right. What is the thalassemia intermedia? How to clinically be diagnosed thalassemia intermedia?
Okay, so clinical diagnosis, I don't know what is this question. So thalassemia intermedia or thalassemia carrier is the less severe form of thalassemia. So they will be having mild anemia most of the time. And this is usually asymptomatic, and most of the patient is not diagnosed at the early ages because they are asymptomatic. Maybe the physicians are more diagnosing thalassemia intermedia or carrier compared to pediatricians because they are asymptomatic. When they come to some other problems, as an incidental finding, mild anemia, then we investigate, we find that. Anyway, the investigations and the confirmations, those things are similar to thalassemia. So you will see the full blood count same, then you go for blood picture, then you do the HPLC to confirm your diagnosis. So only the clinical presentation is different when we compare to the thalassemia major and the thalassemia intermediate. And obviously the treatment is different. Thalassemia intermediate or carrier, we don't need to go for regular blood transfusion. So they don't develop iron overload and the complications like thalassemia major. But these patients also, in the management perspective, iron is not an actual treatment. So we may have to give on and off blood transfusion if the hemoglobin drops. So if they are very much symptomatic, and we observe them.
The next question, sir. What is the hemoglobin level for transfusing asymptomatic anemic patient with iron deficiency? The next question is symptomatic patient with iron deficiency.
Yes. So as I told you, maybe somewhere the anemia, there's a grading. So severe anemia is the hemoglobin below 7, and 7 in between 7 and 10 we say moderate anemia, and maybe around 10 to 11 or 12 we say mild anemia. So whoever is symptomatic, and if you think that symptom is due to anemia, because patient may be telling about thalassemia, tiredness or anything, there may be other possibilities also. For example, hypothyroidism is another common cause in the medical wards coming with tiredness. So if you think this symptom is purely due to anemia, then as a symptomatic patients need blood transfusion. That is in terms of symptoms. But usually we go by the number in thalassemia. If anybody is having hemoglobin below 7, until you reach the hemoglobin 7 or little above, we will be giving the blood transfusion. For example, some patient is coming with hemoglobin of 4. So at least that patient needs 3 units of blood transfusion to get the hemoglobin around 7 or little above. Then we can start about oral iron therapy.
Next question is, for the oral iron therapy, what is the oral iron dose and the preparation, the frequency and maximum dose we can use when you're going to iron deficiency, and what are the other vitamin supplementation we are giving when you combine with the iron and the iron deficiency patients? What are the other vitamins we are going to combine?
Okay, so this is another common some kind of dilemma in young doctors. So the simple and very easily available iron preparation in all the government sector is iron ferrous sulfate, FeSO4. Ferrous sulfate is the commonly available drug. So you can give that. It's usually one tablet is 200 milligrams. So 200 milligrams, 3 times a day is the one we always go for. But even 2 times a day is sometimes acceptable. So with that, that vitamin C should be given with the iron to increase the absorption. And we may have to give some other instructions to the patient. Say, for example, having a milk or plain tea or milk tea immediately after the meal should be avoided. Okay, should be avoided, because whenever they take calcium or plain tea, whatever it is, immediately after the meal, iron absorption will be reduced. So we have to ask them to avoid that and give iron and the vitamin C. So simply speaking, iron deficiency anemia, those 2 are enough. If you want to combine, you can give some folic acid. That's enough, because we don't need to give B12, because B12 storage usually they are in our body for at least 2 years. So even somebody is stopped all the non-veg and became a pure vegetarian, then the B12 won't be there in pure vegetable diet. So it takes 2 years to get them develop B12 deficiency. So you don't need to combine with the vitamin B supplements. But the other way is correct. In a patient with B12 deficiency, when we try to give B12, so what happens is, in one element deficiency, when we try to replace that element, our body might respond to that element and try to produce excessive, or the bone marrow will be very active in producing these red cells. So during that very active process, there may be transient deficiency of other elements, say B12 deficiency patient. When we start B12, there may be transient deficiency of iron and the folic acid in these patients. So in those kind of situations, to avoid that problem, the people start to give iron as well as the folic acid in a B12 deficiency patients. Likewise, in iron deficiency patients, we try to combine folic acid, sometimes the Pico. But those can be given for a short period of time, then they will be all right. This is up to you. There's no hard and fast definitions how much, what are the things you must give. But in general practice, we do give like that to avoid the problem of sudden deficiency of other microelement.
Next question regarding the IV iron preparation, sir. The benefits of giving IV iron in all heart failure patients, is it the first question. The second, is it recommended to in CKD as well?
Yeah, so I told you, so the oral iron and the IV iron, the efficacy is almost equal. But the only benefit of giving IV iron is you can get the iron stores very quickly. Because oral iron, it takes time to get into the storage. So if you think CKD patients, you have to quickly get the iron storage, because we may have to start the erythropoietin quickly to maintain the hemoglobin. So IV iron is the best treatment. But heart failure patients, I don't think we all anyway thinking about giving IV. And if you think heart failure and patient is having severe anemia, so the balance, blood transfusion is the choice, because we have to quickly increase the hemoglobin. So because whenever you give iron only, it takes time to increase the hemoglobin, because we are giving iron, the body should produce hemoglobin. But when we give the blood transfusion, hemoglobin straight away going into the body. So the choice for a severe anemia and the heart failure is going to be definitely blood transfusion. So how are you going to give blood transfusion, and how much of blood transfusion you are going to give is our task. That is our challenge, because when you give excessive amount of blood, we are increasing the intravascular volume, and it may give more work to the heart, and this can cause or worsen the heart failure. Therefore, we generally, if some, say for example, patient with a hemoglobin of 3 or 4 and the heart failure, of course, we have to start the blood transfusion. We always go for not the whole blood, we always select the RCC, red cell concentrate, and we give slowly. In addition, we start midway furosemide to avoid the volume overload issues. But IV iron may not be the best choice for the heart failure patient. Giving blood transfusion, then followed by starting maybe oral iron, may be more appropriate than the IV iron.
Same time, can you tell exact the hemoglobin we have to maintain in heart failure patients?
Yes, so remember, so I told you below 7 is the severe anemia. So generally speaking, go up to 7. But in a patient with heart failure, 7 also may not be appropriate. So we may have to go up to 10 something to reduce the severity of heart failure. Then we can start about oral iron. So we may have to give little more blood to get the hemoglobin close to 10, maybe more appropriate, because the patient is in heart failure. But that should be done very slowly, not abruptly, slowly before starting oral iron.
Sir, next question regarding again due to iron formulation, the IV iron and the pregnancy. What is the choices? What is the choice? What is the place for IV iron in pregnancy?
IV iron in
pregnancy, sir.
Pregnancy.
Pregnancy.
No, so pregnancy, we don't start IVIN generally because pregnancy is we should not give unnecessarily any other drug, especially during the first pregnancy. We don't think about anything. Commonly due to anemia in first pregnancy is physiological, it's due to dilution, not exactly due to the deficiency. So we don't give anything for the first trimester. Second trimester onwards, we start oral iron. Whatever the preparation available, you can think of. Unless you think patient is bleeding or something, go for blood transfusion. That also, you have to think many times before you give blood transfusion during pregnancy because of these blood grouping issues.
The next question is, what type of anemia you will come across patient with aortic stenosis or valvular heart disease?
Okay, that's again another postgraduate question. So there is a condition called aortic stenosis is presenting with iron deficiency anemia. I think it's Hades syndrome, isn't it? I think.
Yes, sir.
Yeah,
yes, Hades.
It's called Hades syndrome. Iron deficiency anemia is there's association with the aortic stenosis. There is nothing directly related to the aortic stenosis causing, I know, not like that. They will have some colonic problem and there may be bleeding due to the some vascular problem in the colon. So those patients can have association of iron deficiency in aortic stenosis. Other valvular heart disease, I don't know any other specific deficiencies associated with any deficiency. And people say with the many ancient type of valvular replacement might be associated with hemolytic anemia, but that problem is now very, very rare because we have now very well sophisticated artificial heart valves, which will very rarely causes hemolysis. So iron deficiency anemia you can think about due to Hades syndrome in aortic stenosis.
So next questions regarding vitamin deficiencies in anemia. Vitamin B12 deficiency, what are the preparation we are giving? So you have already mentioned why we can't give IV vitamin B12.
I don't know why can't we give. It's always given IM. I don't know.
Okay, the next question is maybe it's a storage, that means IM, maybe the depot.
Yeah,
maybe there is a reason. The next question is vitamin B12 and metformin. Metformin is the books mentioned. The literature mentioned the vitamin D deficiency in metformin. So the question is, our audience is asking whether we can consider prophylactic vitamin B12 supplementation when the on metformin for long term.
No, we never think about vitamin B12 prophylaxis in a patient with metformin. So because it's a rare presentation of very, very rare side effects of metformin. Okay, it can very rarely cause hypomagnesemia. Sometimes it causes calcium also reducing and B12 deficiency. Those are very rare possibilities of the metformin. Metformin is the one and only ancient drug and had undergone thousands of clinical trials, and that is the best drug to control type 2 diabetes. And that is the drug can be given during pregnancy, and there are so many trials going on for type 1 diabetes as well, the metformin, whether it is effective. And in addition to controlling the blood sugar, metformin has thousands of other advantages. So the first line drug in a type 2 diabetic patients is metformin unless contraindicated. Say, for example, they are having diarrhea or severe loss of appetite due to metformin, then you may stop that. Otherwise, metformin is the drug. You should not think about giving prophylactically vitamin B12. Nobody will accept that. It's not really necessary.
Next question regarding vitamin, the folate deficiency and the anemia. Is there any specific clinical features like vitamin B12?
Almost folic acid deficiency and B12 deficiency, no, there's no any specific clinical features like B12 deficiency, and folic acid deficiency is very rare also. Okay, somebody who maybe undergone GI surgeries, say for example, removing the colon or anything, because the colonic microflora is the main source of folic acid in our body, and other source is the green leaves. Green leaves also having a lot of folic acid deficiency. So folic acid deficiency is a rare clinical manifestation. Especially, I don't think we see patients with folic acid deficiency in the clinical practice. So it's basically a theory component for the clinical or questions, exam question papers you might get for folic acid deficiency questions. Otherwise, you won't see many patients with folic acid deficiency.
So next question regarding CKD patients and anemia. When to start erythropoietin, and what are the things you should see before starting erythropoietin in a patient with CKD?
Yeah, I
with
think
anemia.
I may have
You have
answered already. Yeah, ferritin is the very important investigation, and the timing of ferritin is very important. There should not be any inflammation. If you see the inflammation is going on, and you have to decide about erythropoietin, and always go for transferrin saturation. Okay, transferrin saturation is the best investigation if you couldn't do the ferritin levels. And if in terms of ferritin, two numbers, 100 and the 200, should be there before you start erythropoietin. Dialysis dependent patient, ferritin should be more than 200. Non-dialysis patient, at least it should be 100. But if you want to do the transferrin saturation, at least it should be more than 20 or 30%. It's transferrin saturation comes in percentage. So at least it should be more than 30% before you start erythropoietin. And usually the erythropoietin needs a loading dose. They will be giving maybe 4,000 international units subcutaneously every other day for first week. Then the second week onwards, it's given weekly subcutaneous injection. Only thing is, it may increase the blood pressure. So we have to check the blood pressure and continue that. And remember, erythropoietin in any case should be avoided in polycythemia patients because it is going to increase the hemoglobin. So on top of high hemoglobin patient, if it is given, that might cause hyperviscosity related problems.
So same question audience is asking, whether is there any significant measurement we can do regarding erythropoietin deficiency before starting the erythropoietin in the CKD.
That is
Whether
the
there's a test.
ferritin.
Only the ferritin, yes. Exactly. So next question is, after you continue in the oral ions or IV ions, how do you set up the cutoff to continue therapy or discontinue therapy?
Okay, so you have, say, for example, CKD patient, you have decided to give IV iron until you get the ferritin level. Ferritin, say, for example, somebody, your target ferritin should be 200. So when you do that ferritin, for example, 10. So it's very low, you have decided to continue. So if you see, there are formulas. It's simple formulas available. You can online, you can search it. So there are numbers, what is the hemoglobin, what is the target raise, everything is there. You put your numbers of your patient's numbers in the formula and you will get how much of IV iron you have to give. Then there is a maximum dose also. I think 1 gram is the maximum dose or something for a day.
Yes.
So you go by that and give it. It is not a emergency treatment. So it is, there are formulas to calculate the dose and follow that until you get the ferritin of 200. Then you stop it and go for erythropoietin. Then you can start oral iron to maintain the iron storage in the body.
So last question. What are the clinical and the peripheral blood count details in a patient with anemia which indicate underlying malignancy?
Very rare, how very difficult to say the underlying malignancy. Remember, so if you suspect malignancy, because in normal life, there are questions about whether we have to treat the numbers or we have to treat the patient. So I would say in clinical practice, more than the numbers, we should think about treating the patient. Whenever you get some numbers, always cross-check whether this number is a possible number for your patient and look for other clinical features. As a whole, you have to treat. Don't worry about the numbers. So malignancy, more than these numbers, there will be a lot of other symptoms. So ask about the symptoms. Say, for example, if patient maybe have severe loss of appetite, very important loss of weight, night sweating, ongoing low-grade fever for a long period of time, with other associated symptoms depending on the site of malignancy. So those are the things you have to consider when you suspect malignancy. And remember, retic count may be another good investigation whenever you suspect malignancy, if you think bone marrow involvement. And also whenever you suspect lymphomas, LDH is another very important investigation. So you can do, in addition to the full blood count blood picture, LDH and the retic count whenever you suspect malignancy, especially the hematological malignancy. Then immediately arrange ultrasound scan abdomen and ask the hematologist urgent opinion. Because sometimes the full hemoglobin may be 10. You will think it is simple mild anemia, but they can have hematological malignancy. You have to see it as a whole patient, not the numbers when you suspect malignancy.
With that, sir, we can wind up this Q&A sessions and our lecture series. So first of all, I would like to thank again Dr. Mayurathan joining with us to give us a lot of knowledge regarding this valuable topic we encounter day-to-day practice. Thank you, sir. And let me thank Sri Lankan College of Internal Medicine, as well as its president, Dr. Ganaka Senaratna, and the coordinator to the Helping MOS program, Dr. Nandini Nanapakas, and last not the least, our continuing the audience who has joined with us, even with very difficult time with the connection issues as well as a lot of country issues. So thank you everyone for joining with us. To conclude our session, I will hand over the session to Dr. Romali. Thank you.
Thank you very much for inviting me. It was a nice experience. I hope at least some of you may have received some message about evaluating a patient with anemia. Thank you.
Thank you very much, sir. We have been receiving overwhelming response for your lecture. I would like to apologize to our participants about the situation where most of y'all could not log in. We provided a live YouTube live stream for y'all to view. Since there would be a problem with y'all trying to obtain the e-certificate for the CPD points, we kindly ask you to contact our Shri office through our number or our email so that we can come across to you and provide you with the e-certificate at your earliest convenience. Thank you very much, everyone, again for joining in this very interactive session. And we hope to resolve all these technical difficulties and hope that you will all join us again next Sunday. Thank you very much, sir, and thank you, participants.
Thank you.